Hi, everybody. Thank you so much for joining us tonight, and thank you for your patience. I know we had a little bit of a late start, but we're very, very thrilled that all of you are here for what we are confident will be a tremendously informative evening. My name is Kathleen Donovan, and I have the great privilege of working at your Parent Resource Center here in Arlington Public Schools. And my colleague Kelly will tell you a little bit more about the PRC in just a moment. Just a few details. There are restrooms out through this hallway to the right. There's also plenty of space down the hall to take a cell phone call if you happen to need to answer a phone. It's just reminding me that my phone is probably on somewhere, so if you have a phone and you want to put it on vibrate, that would be very, very helpful. The other thing I wanted to let you know is that because we're hoping that this information can be shared widely with other families and staff members who weren't able to come tonight, we were able to, and thank you to our director, Paul Jamelski, who's here in the back, we were able to videotape this session. So we just wanted to let everybody know that right now, I think the only thing that should be on the video are the people up here. But if you have a question to ask, just be mindful that it's being videotaped. If you don't want to ask, and I think we'll turn off the camera during the Q&A session, so we'll let you know when the camera's turned off. But if there's anybody who wants to be extra sure not to be in the video, you can either move to the back or move to the side. Okay? Any questions about videotaping? Everybody okay with that? Great. Alrighty, so Kelly's going to tell you a little bit about our Parent Resource Center.
Yeah, just real quickly, everyone. I'm Kelly Mountain. I'm the other coordinator at the Parent Resource Center. And we do a lot of things. We have a lending library. We have tons of resources that families are welcome to check out. We can get them to you very easily. We also do a lot of individual consultations with families. So if you have a concern, if you have questions about your child's development, you can always call us or come in and meet with us. We are so happy to do that. One of the other things we're so happy to do is to support our great SEPTA, special ed PTA folks, in providing different workshops. Kathleen and I also provide a lot of workshops and trainings for families throughout the school year. So we welcome you. We welcome anyone. And you can check our website to look at our calendar of events and everything that we have lined up it's usually for the next month or so. So again, thank you so much for coming tonight, and come see us or call us if you need anything.
So we were very thrilled. This session actually would not have happened without the two women standing to our left, Jana Dressel and Cara Abercrombie, who approached us and said, gee, would love to do something related to epilepsy. It's a situation and a diagnosis that many families are experiencing. And we've never done anything on this topic before, so we were very excited, and we decided we were going to try to pull it together quickly so that we could do it during Epilepsy Awareness Month. So I'm going to let Jen and Cara take it from here, and Kelly and I will be back to chat with you a little bit later in the session.
Wonderful. Thank you, and welcome everyone. Again, I'm Jana Dressel. I'm the president of the Special Education PTA. If you're unfamiliar with the SEPTA, there is some information at the back table near the sign-up sheet on how to join, or if you have questions, feel free to grab me at the end of the meeting. We are a very large PTA that serves all of Arlington County, so preschool all the way up through high school, all schools and programs in Arlington. So it's a fun group of families and staff, and we are excited to be able to support our students. And this is Cara. I'm going to let her take it from here.
Thank you. Hi, Cara Abercrombie. I have a 11-year-old with epilepsy. We are starting an Arlington Epilepsy Support Group listserv. So on the lined paper in the back, if you're interested in joining, please sign up. And this will just be a resource where we can share information and offer mutual support among families or APS community in Arlington. But I am thrilled to introduce our guest speakers tonight. The Children's National Medical Center has an epilepsy center, which is, for those of us with the diagnosis, know it's important that you see an epileptologist, not just a neurologist. And so we are thrilled to have Dr. John Schreiber, who is an epileptologist and also works in the genetics clinic at Children's and helped us get our genetic diagnosis. And Corinne Brandt, who is a family therapist with the Epilepsy Center, working with families and children with epilepsy. And so they will kick off this evening's event. Thank you.
Yeah, thank you so much. Thank you for organizing this, and thank you so much for having us here. We're always happy to speak at events like this, and just so great to see so many people interested in this and wanting to become involved and talk about this. I think that's one of the really important things to do, is to talk about epilepsy and seizures and how we address it, how we treat it. I think what a lot of people find is that when you start mentioning someone who has seizures, who have epilepsy, people seem to come out of the woodwork. I'm not sure if you've had that experience or not, but it's something that people don't talk about a lot unless you share about it. It just to discuss the overall, what we call the epidemiology, it happens in the U.S. in about 0.7% of people. So just almost about every 1 in 100 people here in the U.S. have epilepsy. So surely most people know someone who is dealing with it. And we're thrilled to be here. So Corinne and I, as Cara and Dan were saying, work with the Comprehensive Epilepsy Program at Children's National Medical Center. I also work at Pediatric Specialists of Virginia. So at Children's National, we have 9 epilepsy specialists there, or epileptologists, and we work with a big team of people that includes those epilepsy specialists. We have a big neuropsychology team. We have our family therapist. We have neurosurgeons. We just have a huge amount of support and resources there for families and for patients who are dealing with this. And I'm very privileged to be able to work with that kind of comprehensive team, because you'll find as we're talking about some of these issues tonight, you need a big team like that. You need a big support network. As a parent, as a patient, and as a clinician too, I'm happy to have these resources. So we'll have some time for Q&A, I think, at the end, but just to get into some definitions and what a seizure is and what epilepsy is briefly, and then we'll talk kind of how we manage things and what other kinds of things that can accompany epilepsy, what things can kind of go with it. And in many cases, it's not always the seizures that are the most problematic aspect of epilepsy. Some of you might know this. There are things that can go along with that can oftentimes be more challenging. So a seizure is an electrical disturbance in the brain that produces some kind of change in the person. Sometimes you can see that change, and sometimes you can't see a change very easily. It's something that someone may describe to you. We diagnose seizures clinically, so you probably know that we can do a test called an electroencephalogram or an EEG that looks at brain waves. Unless we happen to catch a seizure on the EEG, we won't necessarily see anything abnormal on that EEG. So most people are diagnosed with seizures or diagnosed with epilepsy just based on getting what we call a history. Now, epilepsy is a really broad definition. So the way epilepsy is classically defined is you have 2 unprovoked seizures separated by more than 24 hours. So that is a huge range of people. You have people who just have 2 seizures and never have another one, and they have epilepsy. And you have people who have dozens of seizures per day, and there's a big spectrum there. Now, we have all sorts of different therapies for seizures. The first line is usually medication. So once we determine that we need to treat someone to prevent additional seizures, we'll usually start them on an anti-seizure medication. And I like the term anti-seizure medication because these medications actually aren't anti-epileptic. They don't change the chance that you're going to have epilepsy or seizures long term. They change the chance you're going to have a seizure while you're taking it. And they're not 100%. They don't work 100% of the time. The first medicine you choose has a chance of working adequately in about 50% of cases. And then you go on down the list of what medication you might choose next or what therapy you might choose next. And there's certainly other things you can do for seizures besides medications. There's dietary therapies, and we have a very robust dietary therapies clinic at Children's National. There's surgeries. There's all different kinds of things that you can do for seizures. But first line is usually medications. Now, medications, as you know, can have side effects. These medications all act on the brain. And as a consequence, many can cause changes in mood, changes in behavior, can cause drowsiness, and depending on the medication, can cause different kinds of side effects. We choose medications largely based on what seizure type we're trying to treat, but also based on the medication side effect profile. So we tend to first choose medications that have fewer side effects. The adage in epilepsy treatment is that you try to make someone seizure-free with using the least medicine you can at the lowest dose, ideally just one medicine if possible. But it's not always possible to do that. So you may, as parents or professionals who deal with students who have epilepsy, have seen kids who are dealing with the consequences of changing medications around. And sometimes these side effects can be transient, they get better over time, and sometimes not. So you may notice that a child who's changing seizure medications around might be more tired from time to time. They might have some problems getting through the cognitive load of school. And that's certainly something that can happen and something that's really important that we try to address. Seizures themselves can also have consequences. So we call the seizure is an ictal event. After the seizure is post-ictal. So some kids can have a post-ictal period that's very brief or not even something you would be able to recognize after a seizure. And some kids after a seizure, it depends on the type, can have a very prolonged post-ictal period where they're very sleepy or they are sleeping and they can't go right back to their normal activity. So to manage this, we have seizure action plans, and you guys, I'm sure, have all seen these seizure action plans. There's one the Epilepsy Foundation has made, and a lot of schools have adopted this. I think each school system has their own seizure action plan, but they're all about the same. You want to know what kind of seizures a child has, what do we call them, what's the terminology, but what do they look like, how often are they occurring, and what do you do in response to a seizure, and we'll talk about that a little bit. And then if the child has a rescue medication, what do you administer, and when do you administer it? What are your criteria for doing so? And some of you who take care of my patients might know that that's not always the same for every kid. And sometimes that requires some back and forth, some discussions with the nurses at the school, staff at the school who are here in the front line taking care of that child, and the parents who are taking care of that child. So we'll, I think, chat about that a little bit right now. So first, seizure types. Seizures can either be focal, meaning coming from one part of the brain, or they can be generalized, meaning they appear to come from all over the brain at the same time. There's all kinds of different generalized seizures. The ones that people mostly know about are grand mal seizures or generalized tonic-clonic seizures, and those are rather, you're not going to miss those. Those are rather violent, rather impressive. Kids, they will stiffen up, often abruptly, and that lasts anywhere from 20 to 40 seconds usually, and then we'll go into the clonic, that jerking, rhythmic jerking phase we call the clonic part of the seizure. And after it's over, seizures almost always stop on their own by 5 minutes. And afterwards, you'll be out of it, tired, sleeping. There's also just tonic seizures where you can just stiffen up. Those often don't last as long, but can occur very frequently in some kids. And then absent seizures are also a form of generalized seizures. These are the staring spells that kids can have dozens of times throughout the day, especially those that interrupt activity. It's all kids stare. My own kids stare all the time. and that's normal. But what's not normal is if you're staring and not responsive to some kind of physical stimulation. So going up and tapping a kid on the shoulder and they're not responding to you. That could be a seizure. And especially if you see something, a staring spell that interrupts activity. So they're in the middle of doing something and then all of a sudden they just stare like that. That's a much more specific sign of an absence seizure. Now, absence seizures they're brief and they don't have a post-ictal period. The kids will go right back to their normal selves right after that. Then there's focal seizures, and focal seizures can appear different depending on where they're coming from. And those can also just be staring staring and unresponsive. But those are usually longer than absence seizures. So those can last on the order of minutes, and they can have a post-ictal period where they'll be out of it afterwards. Sometimes you can have jerking or stiffening on one side that can accompany that, and they look a little bit different. We treat them a little bit differently. So when you see a seizure, what do you do? Well, in a kid who's known to have epilepsy, it depends on the seizure type, and it depends on how long the seizure goes on. So first, what we tell parents to do at home is when you see a seizure, look at your watch, time it. That's hard to do because seizures they're scary to see. They're scary to witness, especially if it's your own kid or a kid you're seeing day in, day out. You want to make sure the child is in a safe location. You don't have to restrain them, stop shaking or anything like that. Just make sure they're in a safe place where they're not going to hurt themselves. And if they're lying down, it's best to have them lying on their side. Sometimes you can vomit with a seizure or after a seizure, and if they do so, you don't want them to be lying on their back, so they'll get back down their lungs and aspirate. Now, most seizures stop before 5 minutes. Some don't. And in kids who are prone to having seizures that can go on longer than that, they'll usually have a rescue medication. And that rescue medication can be different depending on the type of seizure, the age of the child, and their history of prolonged seizures. Our best proven medication for stopping a prolonged grand mal seizure, generalized tonic-clonic seizure, is Diastat. And you might be familiar with that. It's a rectal gel. It comes in a syringe. It's dialed to the appropriate dose for the child and can be administered rectally. For most grand mal seizures, you don't want to be putting anything in the mouth. You don't want to be putting your hand or anything in the mouth to prevent you from swallowing your tongue. That's not a concern. It's more a concern that you'll put something in the mouth they will then choke on. So the Diastat bypasses that oral route, and the medication is absorbed very quickly and works just within a couple of minutes to stop a seizure. Usually if a seizure is going on that long, you're going to be calling 911 from the school as well, but that's something that can be given to stop a seizure and sometimes prevent the need for the child to go to the ED. We use other medicines for seizure rescue as well, especially for partial or focal seizures. You don't always have to use a medication like Diastat. So you will see us using things sometimes like clonazepam. There's a disintegrating tablet that can dissolve in the cheek. That's something you don't have to swallow. You don't really have to worry about them aspirating on that, since that'll dissolve. And that might be a better solution for older kids where they don't want to have their pants pulled down in the middle of the class when they have a seizure and have that risk, have that concern. There's other things like you might have a student or a child who has had nasal midazolam, and that's an option as well. These are all similar kinds of medications, just different routes that you can give them. There's some issues with giving nasal midazolam, namely that it has to be compounded by a pharmacy and it has to be given every 30 days. That compounded medication only lasts 30 days, so you have to use it frequently enough to warrant picking up a prescription each month. So that's the seizure action plan and seizure rescue. Seizure monitoring is something we talk about from time to time too. So for most patients that I see, my goal is to try to keep them in school, because keeping a kid in school is like keeping an adult at work. You want to keep them active and involved and engaged and at a place where they're going to improve. This is where they're getting better. I'm just trying to prevent seizures from happening. I'm trying to remove those barriers of their cognitive development, and this is where they're going to make the most progress and really get the most out of their education. So I want to have them in school if at all possible, and there are different accommodations that we can talk about this some more, that we can recommend, and I'll often work with with staff at school, or try to work with staff at school here to address that. In some cases, it's useful for me to talk to the families first as well, just to get a sense of where things are, if something has changed in regards to their seizure frequency or seizure type. It's best to sort of address those things first and then discuss a plan with how we change the monitoring or the treatment plan at school. So some other things that can accompany seizures and epilepsy, and a seizure and epilepsy diagnosis. A lot of kids who have epilepsy of any type, there's all different kinds of epilepsies. You can have those that are considered more benign. We're moving away from using that term benign because we know that epilepsy really often isn't benign. There's problems with attention, there's problems with language development that frequently come along with that diagnosis, no matter how benign one thinks it might be. We're using a term self-limited epilepsy, in that kids do outgrow many forms of epilepsy. But we do have to watch out for problems with language and attention in particular, in addition to other cognitive issues. So having a 504 plan in place, having evaluation for an IEP is often appropriate. We also do neuropsychological testing. As I mentioned, we have a really big neuropsychology team at Children's National that can help us to appropriately address and determine a child's strengths and weaknesses and formulate a plan that hopefully the school can adopt to really tailor an educational plan for that particular child. There's social aspects that go with epilepsy too, right? We know for adults who have epilepsy, they're less likely to hold down a job, to live independently, less likely to be married. And that all starts in childhood. That starts here in the school, and trying to give them the support they need so they can live independently, so they can lead productive lives going forward, at least as much as possible. So we have lots of resources here that I think Corinne will get into in a bit that help to address those. And a lot of that is just support from teachers, parents, family, friends, and education like this. What things have I not mentioned?
I think you've mentioned a lot of them. I think those of you, who are dealing with epilepsy know that the day-to-day life is a lot of the difficulty. We have to look at things other than just the seizures. That's just one small part of this whole puzzle. It's just much more of a family systems issue and a systems issue affecting all areas of life, almost all areas. So it's very important to have supports and to take care of yourself, and remember those things that are hard to think about when you're just trying to figure out the seizures and monitor and the medications. So I think, one thing to realize is, first of all, just looking at the family system is one, and the impact it has on parents. Every person in the family is going to be different in how they react and understand what's going on. So it's generally the children that don't have as much of an impact because they're not the ones witnessing it, and they don't remember typically what happened or that it's happening. And then you have the parents and the siblings sometimes who are depending on how dramatic the seizures are, who are witnessing it and monitoring and responding, which can be much more traumatic and stressful and lead to a lot of anxiety. Sorry. That's okay. So that's, those are things to consider, that they affect, all different areas. The other thing that they can affect, or they have comorbidity with, mentioned attention deficit disorder is one, depression, anxiety, mood, behavior. So those are things to really be aware of and kind of cognizant of those, some of the symptoms of those, so they can be addressed and talked about with the neurologist and other professionals if you need. And some of the, you may be aware of some of the characteristics would be, depressed mood, could be irritability, lack of finding pleasure in things that used to be pleasure, kind of low motivation to do things, sense of fear or anxiety that doesn't seem to necessarily be related to any one particular thing. And so those are things to kind of be aware of and figure out whether or not they need some additional treatment for those areas. And then another area is peer relationships. And I mean, one thing we talk about, it's so important to, in all these areas, to try and maintain is typical of, peer relationships, social activities, sports, that is possible. We want the children and the families to be able to do everything that everyone else can and not limit. So I think with peer relationships, sometimes it's finding out who to tell and how to tell them. Maybe not everybody needs to know, depending on what your seizures are like or what your relationship is, but it's important to still have sleepovers and outings and go on field trips and those, all those important things that other kids do. The other issue I think we mentioned we're going to get a lot more about is the school, how it can affect school, both with your peers and teachers and learning overall. And sometimes schools generally do a great job of partnering and really helping to kind of understand the individual needs of the child and the individual plans and having that communication, with the doctors, with the families, and usually is a good relationship, I think, with most of the school systems we've had. Sometimes some things that you run into is a lack of understanding or information, and some schools can get, or staff that aren't as familiar, they haven't had a child with seizures, can get anxious and sometimes will over-function, meaning they'll call and for every seizure, if it's a child that's having several seizures and needs to stay in school and doesn't need medical attention, they might feel a need or wanting to call right away and call it 911. And so those are times that we kind of have to work with the school and give them a little more education and help them understand when the child needs medical attention and when they don't, based on their individual types of seizures. And then I've run into other times where children, some of the kids are having either side effects from medication or their seizure activity might increase at certain times, and the schools have difficulty distinguishing, is this really a seizure? Is this child really, are they trying to get out of things? Are they just don't want to study? You're saying they don't have time for homework, but we have children that are having seizures at night and they're exhausted, or they're having them in the day. And so we really have to look at the individual needs of the particular child and really communicate some of those with the different teachers, and then the nurses can really help with that too, and educating and providing that information. One of the most important things I think is for families, for people to have a support system, a strong support system. That can be extended family, it can be friends, it can be, religious organizations, it can be, just getting out with a close friend and getting out of the house and doing something and not thinking about all the difficulties that go along with this condition. And then sometimes there's a need also to have some professional help, whether it's family systems, a therapist that can work with the family, the siblings, and the parents, or cognitive behavioral therapist to work with the child or individuals who might be having some anxiety or depression or other issues going on. And I think setting up the link that you guys are doing is going to be great to connect other parents. They have an atmosphere to share. We run a support group at Children's, so once a month, so that parents can get together. And at the same time, we also run what's called Haywire, which is a teen group. It's actually, 8 ages?
8 to 21 or so.
8 to 21.
Yeah.
So they're able to do activities and get education and have a safe place to talk about their epilepsy. They can invite siblings and friends. And then while the kids are in their group, then the parents a lot of times will meet with me and we'll just talk about whatever's going on, whatever needs they have, any resources to share with each other. And it's as you guys probably know, it's a safe place, and maybe sometimes the only place you can really talk about what's going on in your feelings, and having somebody that really understands what's going on. I can leave flyers on those two.
And that's at the Fairfax location.
Yes.
And at the DC location at Children's, depending on which is closer for you.
Yes, and then the other thing we have also is brainy camps.
Yeah.
we have a camp, an overnight camp for children ages, is that also 7 or 8 and up?
I think it's 7, actually.
I think it's 7
I believe it is.
and up.
Camp Great Rock is the epilepsy camp. So Camp Great Rock, if you're interested, is a sleepaway camp. It's a week long. This year I think it's in June. They just actually released it. So if you're interested or know someone who's interested, please refer them to that. There's some scholarships and things available. But camp, it's a fun camp. This year it's at a boarding school in the Blue Ridge Mountains. It's really nice. The food's actually good, which hasn't always been the case. And it's just a regular sleepaway camp for children who have epilepsy that's stable. They have campfires, sports games, there's a movie theater there, there's all kinds of fun stuff to do. And it's the goal of this is for kids to have fun, but also to have a normal summer camp experience and to build resiliency.
And for parents to get used parents get used to not overprotecting and giving them a little
to give
time.
their kids, and there's a doctor there, myself or Dr. Depositary Kapakar are there, and we stay there for each half of the week. Yeah. Thank you so much.
Okay, we're just gonna, we're both, as was indicated, we're both school health nurses, and we do work in the schools. School health works has a nurse assigned to each school. There's a clinic aide in there every day, and then we are usually at one or two schools. And we just want to give you an overview of what it looks like once your student does come to school and has a seizure disorder or has epilepsy, what we do in the school clinic, so that you'll understand and maybe can address send questions our way if you need further clarification. So we have a little slide that's just easy. I'll just read it off as I go.
Thank you.
So the school health clinic procedures, and this would be the same procedure in any Arlington public school that your student would be in. So the first thing is parents contact the school health clinic staff, and sometimes that contact is in the form of, you all have given a myriad of paperwork to the front office, and then within that paperwork are health forms or health medication orders, etc. And the school office always sends those to the clinic. It's always best, if you can, to touch base with the clinic personally, so that we're all on the same page together. So we get whatever we get from the front office, we look at, and the public health nurses, we review all that information, and 9 times out of 10, we will either call you on the phone and or send home some additional paperwork, which is usually the seizure questionnaire, because like Dr. Scribner alluded to, we need to get information about what your child's seizure looks like, what type, what are the triggers for your child, etc. And we'll show you that form at the end of this. So we ask you for more information. Once we've reviewed everything and we gather the information, we develop an individualized healthcare plan. We refer to it as an IHCP. And it's based on your information and input, as well as whatever providers, the doctor, the nurse practitioner, whatever those orders, if there are some rescue medications or if there are some daily medications, all of that is incorporated into the plan of care that we develop for your student. So once we develop that plan, we then review the plan with the classroom teachers and any staff that will have that will be involved in your students' education and care, because we want to make sure that they understand what you've told us the seizures look like, what to look for in addition to that, if there's emergency protocols, if there's a specific medication like the Diastat that Dr. Scribner talked about, then we want to make sure that people know how to do that. So we'll do all whatever training is needed to make sure that the staff know that they're going to communicate with the clinic and make sure that they know to call us and what to do in case there is an emergency with your student. So once that happens, then the nurses, we put the information, the plan that we develop for your student, we put it in it's the student information system that Arlington Public Schools has, which is, I think you would see it under Parent View. It's called, we put it in under the health alerts or the health. That way the teachers have access to that in addition. They have access to that once they put your student's name in. Then there's a way for them to see exactly what your student has. In this case, we're talking about seizures or epilepsy, that your student has seizures, and here's what to do, and here's the steps that you need to take should a seizure occur in the classroom. We can make the changes to this, and do often, at any time. They can change daily sometimes. If a parent sees different activity for a seizure than you have noticed in the past, that's good information to share with us. Conversely, if we or the staff, we work together with the staff, and if your student has multiple seizures in a day, we'll make sure that the staff or the clinic has communicated with you that we might be seeing something different, because I can't emphasize enough the importance of communication, and that we really want you all to reach out to us so that we can be your voice in the school when we're there with the staff. You know, you might call and speak to the staff member in the morning and say, wow, Bill had a really strange, what we think is a seizure, here's what it looked like. And then we would like to know that too, because then we could touch base with the teacher that you might have communicated that with, and make sure that if we see anything else like that, that we give you a call. That's the basic process for this. And then the next slide is, we'll apologize for that right now, but Olga will tell you it's.
Right, so this is what we call the seizure action plan that once we verified, you have confirmed with us that your student has a seizure, we will send you this. We can email it to you as well if that is best for you. We can send it to you via backpack, and you can complete it. That is information that you will, how we want the communication to be in writing into the clinic, and you will check off the symptoms that your child has. And if they don't have it, then great, but just check the ones that apply to your son or daughter. And it's very simple. And then there's another page, please. And that would be
This is the order.
This is the order. That is what we want. That is usually what the doctor will complete for us. And it will tell us the student's name, the school, the grade, the indication, what type of seizure, how frequent, how many minutes. This is when the timing becomes very important, 5 minutes. So when they are with the teacher in the classroom, of course, we would want them to stay in the classroom and help the student. The teacher should do this and help them to a corner. If we know that they're showing signs or symptoms of a seizure, that is what we would want. We don't want them to be taken into the clinic and watch the clock. 5 minutes. If they're seizing for 5 minutes, then that's when the teacher or the aide should call the clinic, bring the diaset, bring the medication. We will come. We will administer it right there. We'll call 911 at that minute. But this is what the doctor will complete for us. 911 is called, they come, and if we administer diaset, of course, they're going home. Okay, so that's, any questions about this? And of course, that form is signed by the parent and it's signed by the doctor, because we need permission from both the doctor and the parent.
And not every student will have one of those. It would be only if your provider, your medical provider, felt that your student needed the diastat or needed some emergency or rescue medication. So not every student that has seizures has medication in the clinic, and that's fine.
Exactly. All right. So this is what Allison was referring. This is the template of what the IHCP looks like. We will only include the symptoms that you checked off on the first form that I showed you on the questionnaire. So we will cut whatever doesn't apply to your student. We'll make it very simple and easy to read for the teacher, the aide, and everyone.
And that is just a template, so
Right.
any additional information that you provide, please call me for any seizure over 30 seconds. Here's my phone number. We'll put those in. Please don't call there's anything that's specific, that's special or unusual, we will incorporate that into, or the last time my son had the seizure, it was X date and it was because he was tired. Any information that you feel you'd like us to know, we do want to know, because we'll put that in, because that's specific for your student.
Right, so please continue to let the teacher know about the symptoms, but let us know as well, the nurses.
That's all.
That's all the information that we have.
Thank you.
Okay, so again, everyone, I'm Kelly Mountain with the PRC, and this is Kathleen Donovan. And what we're going to talk about for just a few minutes is the rights your kids have in terms of accommodations or maybe even special education if they have epilepsy or a seizure disorder. Certainly, there are many, many kids that survive and do very well in the classroom with just general accommodations with the ITFP plans, and that's great. But sometimes, because of a disability, because of a disorder, it rises to a level where the kids require what is known as, and I'm going to talk about a 504 plan. Can I see a show of hands? Are folks pretty familiar with what a 504 plan is? Okay, so good. And just to kind of refresh everyone's memory, and for those that don't know, we have many laws across the country and the state that speak to the rights of our children in this case. Section 504 is actually an anti-discrimination law, and it requires that any entity, and in this case the schools, that receives federal funding, they have to provide access for our kids to give access to general education and also extracurricular activities if they have a disability. Now, there's a process to go through to find a child eligible for Section 504 protection. In Arlington, every school has a Section 504 coordinator. They come to the school, and the process can be very quick. If we have outside information from a physician, we have a diagnosis of epilepsy, that's the first thing we need. We have to have some sort of a disorder or an impairment. The second thing we need to find a child eligible is impact. Is there a substantial impact on what the law calls a major life activity? Very broad under 504. Can be learning, walking, sleeping. So if we have those three criteria met, a child is often found eligible for a 504 plan. That process can be one meeting. And it's at that point where this plan is developed, and these protections can be anything from cueing, breaks, a rest period after a seizure, routine medication administration. So it's very dependent on what the child needs. The bar, as I said, is much lower for Section 504 when it's compared to special education, but it does allow our children that need more accommodations than just standard classroom accommodations a level of protection so that they can access the curriculum in the regular ed setting. Any questions on that? Okay, Kathleen?
Okay, and I'm also going to be very brief because we really want to turn it over to our parent panel. But as Kelly mentioned, there are multiple different sets of legislation that provide and afford rights to students with disabilities. The Individuals with Disabilities Education Act, often known as IDEA, falls kind of under the larger umbrella of the ADA that also covers the Section 504 that Kelly was talking about. And the Individuals with Disabilities Education Act basically tries to ensure that all students with disabilities are identified and provided with a unique set of services designed to meet their learning needs. This is a definitely longer process. It's never really just one meeting, but anybody who suspects that a child has a disability that might require specialized instruction, which is what we call special education, can refer the student to the local school district. So that could be a parent, it could be a physician, it could be a nurse, it could be a teacher. Anybody who suspects that will refer to their local public school district, and this starts what we call the special education cycle. Kelly and I spend a lot of time at your Friendly Parent Resource Center really trying to support families to walk through this process. So, and we offer a 3-hour class just on the process, but basically the quick takeaway is that if a disability is suspected, where we see both the disability and adverse impact on the child's education, that child might go through this process of being evaluated for consideration for special education. And when I say special education, what I mean is not a place, it's a set of services that are specifically designed to meet the unique needs of a child with a disability. And that may require this assessment, certainly would require some assessments. And what happens is that the services are provided through something called an IEP, which stands for Individualized Education Program. And coincidentally, Kelly and I have a class coming up on November 29th, another 2.5, 3-hour class to tell you all about the IEP. But an IEP is a wonderful thing because it's developed by a team that includes families to address those unique needs. And in short, the IEP team, if the child is found eligible and all of these steps require parental consent, if the child is found eligible, then an IEP team will meet to identify what are the child's strengths, because we want to focus on those, and we also want to focus on their educational needs, and write an entire plan that will include potentially specialized instruction, related services like speech therapy, occupational therapy, and some of our students with epilepsy may also need support to compensate for related learning disabilities or cognitive impairments. So if you find yourself in that situation, we'd be more than happy to meet with you, talk with you about the process, and provide any support we can. So that's my 3-minute, summary of our 5-6 hour sessions. Any questions about IEP or the process or special education? Yes, please.
Maybe a 504
Sure.
question, but we began the child find process, but that doesn't naturally trigger a 504 process, is that right? How do we start that?
That's a good question.
So that's a really good question, and sometimes it depends on, often what I would recommend is that you talk to whoever is kind of, are you at elementary level?
She's 3.
Okay, so yeah.
Does 504 apply to 3-year-olds?
Yes.
Well,
IEP, yeah.
504.
I would, I would talk to the Child Find coordinator about that. I'll be honest, I don't know of many or any of our preschoolers that have a 504 plan, but that's not to say they couldn't. But I think I'd start and talk to the Child Find coordinator about that.
Right. And typically 504 plans are really addressing the environment that the child is in. So for example, we all came in tonight through this building and you'll notice there are push button doors. So that's a reasonable accommodation to ensure access. So because the 3-year-old's not necessarily in a setting that receives that federal funding that Kelly talks about, I'm not sure what that would look like. But if she came in, then absolutely.
Yeah.
Yes, absolutely. Great question. And parents can also be pursuing a 504 at the same time as they're pursuing an IEP if the child needs accommodations, because that special education cycle can take up to as many as 65 academic days. Any other questions? Kath, did you have a question?
So I have a son who's 12 who has autism and epilepsy, and this past year his seizure disorder has really kind of ramped up, and it's really affected his grades at school. He's in a graded program. And I'm just wondering, like, in terms of, reasonable accommodations, or kind of, what our rights are as parents, or his rights are, in terms of, knowing that it was a huge impact because of epilepsy.
Right.
I just am wondering about sort of how that's going to follow him, and wondering what we can do
Right.
to ameliorate that as much as possible.
So I think that, grades can be something that an IEP team, if the student has an IEP, can absolutely discuss. I mean, we have students who have modified workloads, who are graded based on, modified instruction as well. So I think that might be, it's a bit of a longer question, but I do think that certainly I would request a meeting with your IEP team to talk about that, because that is definitely something that can be addressed through an individual education program. All right, I think Jana and I are going to trade places. And
Very brief because I see.
Right, and Kelly and I will be here afterward, and we know, it's hard to summarize this in just a few minutes, but we're going to switch and invite Cara and Jana to come up and share a parent's perspective about life with epilepsy.
Hi, everyone. We will be fast. I wanted to make 2 points. One, the importance of communication with your school team and community, and 2, speak a little bit about resources in the broader community. We plan to have the Northern Virginia representative from the Epilepsy Foundation with us this evening. Unfortunately, she had an illness in the family, so was not able to join us, so I'll try to give you a quick overview. But on communications, we've covered most of the points I wanted to make. I think in addition to the information you provide your nursing team at the school, take video of your seizures. It is a very troubling thing to do, but that is the best way to show what your child's seizures look like. And we have them on our phones. We have Google Drive docs that have photos of our medicines that we keep, that we can just pull up on Google Drive on our phones everywhere we go. So there are a number of apps and resources to keep all the data with you at all times. I also wanted to elaborate a little bit on the discussion about communicating with transportation. When our daughter was first diagnosed with epilepsy, it was a twice-a-year occurrence, so we didn't really we assumed transportation knew she had seizures. It wasn't until the onset of puberty and things went truly haywire, and it became not a question of if, but a question of when she would need emergency response, that I one morning said to her bus driver, she's got epilepsy, right? She's like, no, I had no idea. And it was a 40-minute bus drive. So we spoke with her school, her principal of her school, to his great credit, got on the phone with Mr. Jamelski and transportation, and they worked out an arrangement where the para in her school agreed to be trained in how to administer Diastat, indeed had already witnessed it many times in the school, drove to our bus stop in the morning, rode the bus with my daughter to school, rode home with her, and was the emergency point person. So there are creative ways to work with transportation, but it's not going to happen unless you drive it. So just want to make sure you're having those conversations. And then second, on resources, the Parent Resource Center, when they sent out the invitation for this event, had a sort of a list of handy-dandy resources, websites, etc. I encourage you to look at that. The Epilepsy Foundation, they're in the back. They're in the back. Epilepsy Foundation has an amazing wealth of resources. I'm sure you've all scanned that in the past, but they have answers to basically every question you might have. I also want to make a plug for an organization called Cure Epilepsy. They run amazing webinars on about a monthly basis, and they've archived them all. So you can just go to their website and see the chats on the latest insights into the genetic research, the latest insights into cannabinoid oil, I can never pronounce that, impacts on learning, comorbidity with ADHD, it's all there. And if you actually go into the webinar, they take Q&A during the time. They're a small dynamic organization, and I've learned more from them, frankly, than I did in the first 3 years of office visits with our neurologist. But please go to the resources, and if you're interested, we are creating a little community of parents to share information, so sign up in the back.
Awesome, thank you. I'm going to be super brief as I am not an experienced epilepsy parent. I'm very new to this process week. My son had his first seizure last May, and fast forward to now, we are still on our third anti-seizure medication. We're having a lot of behavioral side effects. Today he had his first 3 drop seizures. We've never had those before, where he literally just lost, everything on the left side and fell. So I just want to encourage you to not be afraid to reach out. Kara's been great and such a resource to me, but I think just starting to create a community, there's a lot of us out there and we're all at different phases in the process. 2 things that have been really helpful for me, a parent told me about an app called Seizure Tracker. It's free. You keep it on your phone. My son has many, many, many seizures a day. The day after Halloween, he had 35. So it's very hard to keep track of when the seizures are happening and, you're making medication changes. And so it's been a lifesaver because I can sync with my husband. We get notes from school and we can put in when he had seizures at school. So we can kind of consolidate all the information. And then the best part is it prints out graphs for you. So when you go to your doctor, you're not trying to say, well, on average he has X number of seizures. We can literally see times of day he's having seizures. I think somebody mentioned that they're seeing it at a certain time of day. It's just really helpful and it's totally free. So I was so glad a parent told me about that. It's called Seizure Tracker. And then I just wanted to also talk about the importance, I think we've hit it a little bit, the social aspect. Again, my little guy's only in 3rd grade. And to complicate things, he's not a reliable speaker, so sometimes hard to know what he's feeling. But regardless of how old your child is, I think try to have a conversation with them about how they want you to handle it with peers and school. Have them be part of the process. We've had a great experience at Jamestown with his school team, and they, at the beginning of the year, talked to me, and we had sort of a plan on how we wanted to approach it with peers. And his special education teacher went in and kind of gave a little talk about autism, but also about epilepsy, so that his friends aren't scared and they can help alert a teacher if they see something, and it's been really positive. We've used some children's literature to go into schools. A lot of these are on that resource page back there, but this one in particular has been great that we've used with school and peers that have come over, just talking about what seizures are, and it does really talk about all the different types, but it's still very, child friendly without being too overwhelming. And there's a lot of other books like this. So, when you have students who are older, I think they're going to have different ways that they want you to communicate that with family members, peers in school, but try to involve the child as much as you can in the process because, they're the one that has the disorder, And so having them be an self-advocate, I think, is really important.
And also, when it's happening, they aren't aware of it, so it's not in the moment. They can tell you how they want you to handle it. So having it separately from an event sounds like a good idea.
Yeah. I know at our school, they have the general education teacher and the special education teacher, they have a little signal, and the kids know that if they need to leave the room, they see the signal, they pick up their silent reading book and they go across the hallway. It's seamless. I mean, they've practiced it now, and thankfully we haven't had to use it too much because his seizures are generally pretty mild and we can go about our business, but there's a plan in place. So just having some type of plan with your teachers, I think, is really important.
I forgot to add, again, Epilepsy Foundation is also willing to send one of their representatives to do a training or overview for your schools. So that is something to keep in mind if that would be useful to you.
And we want to be respectful of time, but is there any last minute questions? We're going to be staying after as well. So just want to thank you for coming, and we hope this is a really helpful evening for you. Thank you so much.